Yeah. Okay, everyone, I think we're going to get started with the next panel. Again, my name's Caitlin Morris. I work here at Families USA. It's a good thing that we don't do IT here because that would be a problem. I am the Director of Health System Transformation here at Families. And for those of you that aren't too familiar with our organization, we're a national consumer health advocacy group. And we work quite a lot with a number of very diverse organizations at the state level. We focus quite predominantly on lower income populations and communities of color. The Medicaid population is really our bread and butter. And in our health system transformation team, it's kind of our fancy way of talking about payment and delivery reform. So I'm very excited about this next panel, sort of as we move from evidence to policy. I think that clinical practice guidelines are sort of a key link in those two pieces. And so I'm very excited to hear from our diverse panel today. Payers are increasingly relying on clinical practice guidelines to help them decide what to cover. And as we want to build a more consumer patient-centered system, having patients at the center of guideline development is essential. So without further ado, let me please welcome Wendy Bennett, who's our first speaker. Wendy is Associate Professor of Medicine at Johns Hopkins School of Medicine.
I'm an assistant professor, actually.
Oh,
no worries. But,
I'm sorry.
You know, in academics, it's important. So thanks for the invitation. I want to thank Kay for inviting me. And I'm a general internist. Oh, and not on, so I should probably repeat. Probably people heard me, though I can speak loudly. And I'm going to be, does this flip slides? Yeah. So I'm going to be sharing with you some very early data from a study that we're doing at Hopkins, and we're calling it Prioritizing Topics for Clinical Practice Guidelines for Patients with Multiple Chronic Conditions. And this is a case study because we're presenting just some early findings. The principal investigator of our study is Dr. Cynthia Boyd. She's a geriatrician at Hopkins. And our study is funded by PCORI, and it's in their methods portfolios. So those of you that had our slides, if you're interested in seeing the abstract or any information about the study, you're welcome to check out the website on PCORI's site. So having multiple chronic conditions is extremely common. About close to 50% of Medicare patients over the age of 65 have 3 or more chronic conditions, and they consume about close to 90% of Medicare's budget. We also know that multiple chronic conditions is not only in older adults, in younger people too, in large population-based surveys. Many people who have one chronic condition also have another chronic condition. And as I mentioned, I'm a general internist, so I'm a primary care doctor, and this is kind of the bread and butter of what we do in general medicine. You know, all of my patients, practically all of them who come to see me with one chronic illness have one or more other chronic illnesses. And we know we're faced with trying to look up the right evidence for our patients and to make patient-centered decisions. And this is an example of a patient of ours, and there was an article in the New York Times about the complex decisions that she has to face. So the article is treating an illness is one thing, but what about a patient with many? And Dr. Boyd put this together from her JAMA article in 2005, coming up with a hypothetical patient who has 5 moderately severe chronic conditions and kind of a day in the life of this patient. So if you were to take all 5 of her chronic conditions, look at the most recent recommendations and guidelines, this is what her day would look like. So you can see the time, the time of the day. So she wakes up at 7. These are all of her medicines through 11 p.m. And then these are the things she sort of has to do. So non-pharmacologic therapy. So she has diabetes, she has to check her feet because she has osteoporosis and takes alendronate. After she takes it, she has to sit upright for 30 minutes. And then you can see all the things she needs to keep in mind to be guideline consistent all day long. And then these are all of her sort of periodic checks, and some of them are patient education, things she should read about. She needs to come in and see her doctor to get various monitoring. So, and you can see she takes a lot of medications to be guideline consistent. So The other speakers are really going to go over this in a lot more depth, but I think it's helpful for all of us just to understand the definition of what a clinical practice guideline is. And this comes from a combination of the National Guideline Clearinghouse and the Institute of Medicine's report from 2011. So they're statements that include recommendations. They're really focused on helping providers to optimize patient care, and they provide the strongest evidence we have. So they're supposed to take systematic reviews that assess the benefits and harms of the different treatment options, and then most guidelines are produced by specialty medical organizations, but many are now coming out of health systems. And the goal now is that they use a transparent process and that they involve stakeholders, patients, and caregivers and the public. So many of you are probably involved with guideline development processes. And so Cynthia looked at whether the current clinical practice guidelines are relevant for people with multiple chronic conditions, and reviewed 9 different clinical practice guidelines and found that most of them that are focused on a single disease will sometimes talk about what to do if you have another chronic condition, but they don't tend to give adequate guidance for older patients who then have 3 or more chronic conditions, which is really the majority of our patients. So our key question for our PCORI project was, can we frame questions and synthesize the evidence base in such a way that it would better support the way we create guidelines for people who have multiple chronic conditions? And so we have a stakeholder team of investigators that is looking at this question. So our team is made up of researchers. We have researchers from Johns Hopkins and what we call the Zurich team. So these are a lot of people who understand some of the methods. And then we have a guideline group. So I'm going to talk a little bit about them, but it's Kaiser Permanente's guideline development group that we work closely with. And we have patient and caregiver, 4 patient and caregiver co-investigators on our team. And our goal is to identify high priority clinical questions and outcomes for people with multiple chronic conditions, to synthesize the evidence base so that we can support the development of future clinical practice guidelines that will be relevant and inform patient-centered care for people with multiple chronic conditions. And then ultimately, we want to be able to develop the methods for doing this so that other groups, when they're developing their guidelines, they can go back and replicate our methods, and they could also have guidelines that are really informative about how to care for patients with chronic conditions. So these are our 3 aims, and you have those in your slides if you want to look through all the aims. I really wanted to focus for this talk on our first aim because that's the aim we're on now, and that's where we have some results to share. So the aim 1 is to collaborate with people who have multiple chronic conditions, caregivers, and then, as I mentioned, Kaiser Permanente's national guideline program. And our goal is to set priorities for what are the important topics for people with multiple chronic conditions. And we're focused on chronic conditions where at least one of those conditions is a cardiovascular condition, and that's partly because the guideline group that we're working with from Kaiser is interested in cardiovascular disease, and so we've let them kind of guide us in that way. So one of the conditions is a cardiovascular condition. And these are the steps of our process. So we've gone through up to the 4th step, and I'm going to share with you some of the results, but I want to just kind of lay out the steps for aim 1. So we've asked our partners at Kaiser Permanente National Guideline Program to provide us a list of what they think are the topics that they want to do guidelines on. And they gave us a list of 132 topics, which was large. And so our team of investigators used a method, the modified Delphi approach, consensus building among our group, to narrow this down to the top 12 topics that we thought would be most relevant to people with multiple chronic conditions. And then we conducted 2 different focus groups with patients and caregivers who have multiple chronic conditions to get their input about which topics they think are most important to them. And then from this, we've been able to identify the 2 highest priority questions to move forward. And we're focused on 2 questions related to diabetes and high blood pressure. And then the next step is we're getting feedback from patients and caregivers. We're using focus groups to generate outcomes list so that we can understand from them what are important. If we're going to look at these two topics, what are the important outcomes that we need to consider? What are the outcomes most important to you? And then the final step for AIM 1 is we're conducting a survey of patients. So a broader survey to help us prioritize which outcomes are really the most important. So the sweet spot here is we want to get 2 questions to focus on for methods that we're using in AIMS 2 and 3, and these are risk-benefit analysis methods. And so we have patients and caregivers giving input in a variety of different ways, both on the investigator team as well as through the focus groups, and then we're interfacing with our Kaiser guideline group and trying to inform the way they do guideline development that's relevant to this patient population. So I want to share with you some information that we've gotten back from the focus groups. So we did 2 focus groups just recently. We finished them. And these focus groups were done at Kaiser Permanente in Colorado, in Denver. And we had one group with 7 people, one with 4. The participants were diverse, so we wanted to recruit patients and caregivers who had multiple chronic conditions. All participants were older than 50. 2 were older than 80. They had to have multiple chronic conditions to be eligible, and so all participants had, we wanted them to also have one of the 5 conditions that were most important to the Kaiser group, so cardiovascular conditions, and then they also had other chronic conditions in addition to cardiovascular disease. Each group had a patient-caregiver pair, and then the caregivers also had multiple chronic conditions. And what we did was we presented them with sets of our topic cards, which were the 12 research questions that rose to the top of our list, and we had them discuss these questions, and they got to ask questions about them, and really to decide which ones were most important. And then at the end, they did some ranking and voting on which questions were most important to move forward. So these are an example of cards that they were given. They were given 12 of these, so it was, I think, a little overwhelming to have all these cards. But you could see, so the topic here is choice of diabetes treatments. And the question that we're asking is, of people with diabetes, are there groups of people for whom the balance of benefits and harms would affect the choice of treatment? And another that was highly ranked was target blood pressure levels. So should target blood pressure be different for some groups of people? So some things that we heard from the patients is we gave them these 12 topics. We wanted them to choose which are most important, and they said they're all really important, actually. So that was actually important for us to hear, that they felt like all these topics were important to them. In general, participants really spoke about how they don't feel that they have a lot of control over what's going on in their medical care right now. They feel like they're at the mercy of their doctor. They were trying to understand what guidelines were through these focus groups. It was actually something challenging to communicate. And all the participants were very concerned with their own care, and they started to understand what guidelines were about. But within taking guidelines, they really liked the idea of how do you take a guideline and apply it to the individual. Doctor-patient communication is essential, and participants all wanted to be involved with the decision making. And that how a person feels or their well-being was more important to them than the clinical benefit of treatment. So some of the challenges that we faced with this first AIM that I described has been, first, in engaging the guideline group, we want to make sure that the process that we're developing with them is something replicable, that it's something that they can learn from their working with our group and then move on to every guideline that they develop, so that they're engaging patients, caregivers, and also that they're thinking about patients with multiple chronic conditions as they're developing their sort of single disease focused guidelines. The second part is the way we've been able to engage our patients and caregivers. And we have an amazing group of 4, I'll list them at the end, 4 patient caregivers involved on our investigator group. And they've actually really been educating, I think, the rest of the research team in making sure that we explain our purpose and goals to the patients in the focus groups in ways that everybody can understand. And one of the challenges that we had was this idea of how do you eliminate some of the questions. So we presented these 12 questions. There was a lot of discussion, but participants had a really hard time in the focus group saying some were really not important and others were much more important, so sort of making that distinction. And then we really wanted, because we're focused on patients who have multiple chronic conditions, we want to make sure that that patients who are unwell, their voices are also heard at the table, but it's hard to get them to come to a focus group session. So we're hoping that when we do some of the survey work, we'll be able to reach people who can't necessarily come out to a focus group. So the next step that we're working on is selecting the outcomes for the 2 top questions. As I mentioned, there's going to be one on diabetes and one related to blood pressure. And the focus group participants actually started to help us think about what outcomes are important to them. And these are some of the ones that they listed. So stress, taking care of everything alone, being happy, non-medical interventions and their impacts, quality of life, life expectancy with and without an intervention, pain management, functionality, lifestyle, so why take a medication if your lifestyle doesn't improve, and overall well-being. But we're going to do 2 more focus groups to try to figure out these high priority outcomes, and then from that list we're going to do a larger survey and then move forward in this process to do some risk-benefit analysis. So then we're applying these fancier methods. We can come back and talk to you about the fancier methods that Cynthia's group is going to use to try to figure out some of the risks and benefits for these research questions that we are focused on. Oh, and my last slide's not there. I forgot. So I have a thank you slide, which didn't show up. But we have a really amazing group of investigators. Kay is among them. So we have this group, as I mentioned, of researchers at Hopkins. Then we have the Kaiser Permanente guideline group. We have our 4 caregiver and patients who have been involved with all of our meetings. And then we have 2 investigators in Zurich. So it's a large group. So I want to thank all of our hardworking researchers. Thanks.